I want to now introduce our two discussants, Peter Doshi. Dr. Peter Doshi is an associate professor of pharmaceutical health services research at the University of Maryland School of Pharmacy and associate editor at the BMJ. Dr. Doshi campaigns for greater transparency of clinical trial data and leads the Restoring Invisible and Abandoned Trials REART initiative, which aims to ensure that clinical trial publications are accurate and complete and the data are publicly available. Our other discussant is Dr. Sue Golder. She's an information specialist and has worked on optimizing the retrieval of adverse effects data. Her current research is on the use of unpublished data, text mining, and social media to maximize the efficacy and effectiveness of the retrieval of adverse effects data. I'm going to turn this over to you, but one of the questions I have is, when you look at all the presentations so far, starting with a very provocative question of should systematic reviews even be doing this? And although the short answer was no, I think the longer answer over all of these presenters is that there are things that we can do better. So one of the questions for the discussants is, how do we prioritize? There are many tasks that fall to trialists, but there are a lot of things that systematic reviewers could do, and how do we prioritize among them? And I'll turn it over to the two of you, Peter and Sue.
Sure, okay, happy to go first on that. In fact, your question there, Mira, sort of mirrors my own thinking. These presentations were excellent, really interesting, well presented. Essentially, though, you've presented a complete mess. You know, for me, I was thinking, what's the summary? What to sort of describe what I'm seeing, and it's just from the problems in ascertainment, and I think that's a huge one. Starting with the beginning of data collection, this issue of are the adverse events systematically collected? Do we go out trying to figure out how many people have adverse event type X? Versus those that aren't systematically collected are sort of just found maybe if somebody happens to report it. That's a mess. Then we have these huge problems in reporting with these different thresholds. We have problems in how do you synthesize this and then interpret it. And I do like that we have seen some sort of suggestions and some solutions, and I'll probably get back to some of my thoughts on that. But I was wondering if some of the discussants can first sort of speak to what are the lowest hanging fruits here for improving this state of affairs? If the goal is to improve public access to a reliable assessment of the harms from interventions, what are the lowest hanging fruits? And who, for each of these suggestions, who's best in place to institute those kinds of changes to improve collection, to improve reporting, to improve synthesis? So really open to anybody who wants to start with that.
I'm going to take a partial crack at it. So I think, lowest hanging fruit could be different things. It could be technically what's lowest hanging fruit. And technically the lowest hanging fruit would just be to put spreadsheets on the internet with information about all of the different harms that people have collected. But that's difficult. So as you know, clinicaltrials.gov has a threshold for reporting. So the law doesn't require that. And I think that a lot of people aren't going to do that unless, the law is modified or NIH and other policies are modified to require that. Journals could start requiring more complete information. I think, as reviewers, as Rachel said, we want information which might be a little bit different from what we really want in the trial report, because I tend to agree that visualization is a better way of showing what's happened in an individual trial. But we need data in analyzable formats. And so, I think one step is to just make those data available.
Yeah, I'd completely agree. Evan posited putting spreadsheets online, whether that's the thing or, one of the big reasons why trialists don't report all their harms, right, is this sort of perceived space constraint, right, and what they've got for the journal publication, but that doesn't really apply with supplementary materials anymore. It's so easy to put on just if they wanted to put a table of all harms that occurred, it'd be pretty easy to do so in the supplements. So that would that would go a long way for sort of access, I think, for data on what's in the trials. For reviews, I think sort of that low-hanging fruit, easy thing would be just to have more acknowledgement of the challenges. It's still something that is not done enough, or as much as it maybe should be. So that would be something that's quite easy to change. It doesn't actually really require any more information, to just acknowledge that you don't have the information.
Yeah, this is Roger. Just with regard to observational studies, I mean, I kind of agree with Peter. It's real hard because systematic reviewers, at least, are kind of, it's all they can do just to look at RCTs, with all the limitations of RCTs, and then throwing in all these observational studies, with all the, methodologic limitations and all these other things that I brought up. It can be very helpful, but also is a lot of work, and may or may not. I mean, like I showed, there are times when it's very useful and times when it's not, and when the observational studies can actually be misleading. I think the low-hanging fruit is for people to be very clear about what the systematic review is based on, that if they don't include observational studies, to explain why. If it's just resources, we don't have time, just, say it. But at least to explain what's done. And then if they do include observational studies, I think the lowest hanging fruit is just to be able to, separate what the observational studies and RCTs are showing, and then try to at least do some exploration of what's going on. But there was a comment saying that ARC doesn't routinely include observational studies. I don't think that's quite accurate. ARC reviews do actually ask us to at least consider observational studies routinely, and the guidance that I help lead on harm says you should always consider observational studies. It doesn't say you have to include them, but it does emphasize observational studies. But there are whole groups like Cochrane and other groups that don't really emphasize observational studies at all for harms, at least not to this point. And so, there needs to be a pretty big change in kind of the way a lot of reviews are being done, to think about all the different types of evidence that can be informative for harms.
Can I just come in as well to go back to Riez's point about, using that supplementary, as I said in my talk as well, I didn't want to give the impression that we should just be putting all the harms data in supplementary or other sources. I think it's still really important that there's an intelligent interpretation of that harm data in the journal article alongside benefits. So we are getting that balanced summary. It's not here's all the good things, and then go and find some other supplementary material to see the harm. So I think that's something we maybe need from reviewers and editors to make sure that's happening.
There's a couple of questions that I think maybe, Sue, you could help guide the discussion on, and this relates to how you can identify what might be clinically relevant differences, and whether or not one could even come up with those kinds of differences for non-systematically collected harms.
Right, I don't think that's really, I couldn't say what was clinically important. So I think today has been really interesting, though, just to put in another point before maybe somebody else could answer the question about clinically, because it draws on, I feel like I've been in this area for about 20 years. And at the beginning, we were going on about how it was very difficult, and people were very anti putting adverse events into their systematic reviews because they were put off because it is so difficult. And there are so many hard questions at all the stages, from identifying which adverse events you're going to look for, or whether you're going to look for them all, and what types of study designs, which is, can be, an array of study designs. And I remember going to colloquium 20 years ago, and people were very, very put off. And I think in some ways we've got to be careful not to put people off. And I like the idea of being transparent and being very upfront about limitations, so that people feel that they can not saying they should do bad reviews, because that's not what I want them to do either. But I don't want it to go back to where we were 20 years, where people weren't considering adverse events in their systematic reviews at all. Maybe if they acknowledge the limitations, be transparent as already been stated. So I was also trying to think what, I'm a co-convener of the Cochrane Adverse Events Methods Group. I was trying to think what we can do to help the situation as well, because there are so much issues in adverse events. One thing I was going to suggest is that if anybody wants to send me their publications, I'll put them on our website, or any links to any YouTube videos or anything. So at least there's a resource for people to help them include adverse events, with there being, so many hurdles to go through, that might be help. So please, anybody email me whatever you want me to put on the website that's relevant for the methodology. But I can't think of any other ways to help. But I'm happy to listen to suggestions.
I see a couple of questions asking about the potential for research computing and big data. And I think this is possibly related to the question of how, if you don't have a sense of what harms are important and what degree of difference could, for example, either something in the, scraping data from medical records, would that kind of thing help? How far do you have to go in order to identify harms that are not pre-specified and the degree of difference that might be clinically meaningful?
Yeah. Well, I've certainly looked at big data, especially social media, and we've compared it to other sources, and it's very similar to what you end up with is what you get from the search in the FDA database, the FAIRS or MHRIA, because you haven't got your denominator, you haven't got your control group, but their relative frequencies were strikingly similar from what you find on that social media data. And I know people are trying to scrape as well electronic health records. There's a group in America that are, sorry, a lot of you are from America, that are very successful in doing that, and they're finding very similar to what we found with the social media. It's what people are reporting, which may be different. There was a big contrast to what was reported in systematic reviews from this big data, which I think comes down to what Evan was talking about the reporting and the selective reporting and what have you, because we got very different answers from the systematic review than you did from the spontaneous reporting or from social media data.
Thank you. Sorry, go ahead, Peter.
Well, I was just going to respond to one of the things that Sue had suggested, which is that, we continue using systematic reviews to cover harms. And a lot of these, big data sources, observational studies, particularly about drugs, will include information about patients with lots of different health problems, different reasons for using a drug. And so the information from those databases will be relevant potentially to lots of different systematic reviews. And one of the limitations, it seems to me, of the current approach, and one of the reasons it's so much work for every review group to incorporate harms, is that they would in theory have to cover the same data sources, the same studies across lots of different systematic reviews about different health problems. And one of the reasons that I think it would make sense in a way to have separate reviews about harms is that for those things, as Riaz said, that are biologically related to the drug rather than to the condition, I think Roger made the same point, we could cover those studies and synthesize that separately and then apply that information to lots of different health conditions rather than requiring that every review team summarize those same sources of information over and over again. I also think in having different reviews focused on the same interventions and saying different things about harms, there's a great potential to have contradictory recommendations based on fragmented evidence And I think we may be making, conclusions that are incorrect as a result of that.
Yeah,
I mean,
sorry. I wasn't saying that we should include adverse events in all reviews of effectiveness. I just worry that it puts people off doing any reviews of adverse events, whether it's because well, I think it's much easier to do a review of effectiveness than a review of adverse events. Yeah, so yeah, I agree. They can be separate reviews and often work better separately.
Yeah, and I was also intrigued by Riaz's suggestion of systematic reviews specifically devoted to harms. If you think about this seminar we're having right now, it's all about harms, which is interesting. It's not about harm, benefit balancing, and it's about harms. And in my head, harms have always been second-class citizens to efficacy, right? People want to know if the drug works. That's essentially sort of on the street, all that matters. Does it work? And the rest is just, is covered with the well-tolerated sentence, right? It was well-tolerated, safe and well-tolerated. So for the discussants, I mean, do you see any of this ever getting to a point, a future where we have much less ambiguity about harms, where or is adverse events essentially always going to be this subjective realm, depending on argument, persuasion, data visualization styles? Is it complicated data? Can't really say, but it does seem. Are we always going to be in this stage, which essentially seems right for saying, well, it's not clear that really is related to drug or X or vaccine X, right? We're always going to be stuck in this state where we have lots of clarity about efficacy, and this, leave it to the specialists to argue over, and who knows, and they just put that in the label because somebody said it sometime, this very dismissive attitude about harms. Are we ever going to move towards to getting harms on an equal playing field? And if so, how is that going to happen?
So this is Roger. I mean, I don't know if we'll get harms to an equal playing field, but I was just going to comment on this difficulty in weighing benefits versus harms. I think is actually you can. So for example, the U.S. Preventive Services Task Force does this explicitly, right? They say we balance benefits versus harms, and we come up with a recommendation, grade, letter grade A, B, C, or D, or whatever. And but it's actually not really clear how they decide whether having somnolence or risk of falls or whatever weighs against preventing a cardiovascular event. It's not formalized hardly ever, and there's actually a lot of issues there because for statin, for example, if somebody gets a myalgia, it's like you can stop the drug, and how do you weigh that versus prevention of a stroke or something like that? And you can't just take the numbers. You could do this by utilities or qualities and just kind of lump everything together, which may be the only way you could actually really do it formally, which would just kind of take this away from harms and just say, forget about analyzing all this stuff. Just look at, what the utilities end up being. You get a valid measure of, quality of life, and that's what's important. So I think there's actually really kind of different ways to think about how to put this all together. Like right now, we're giving people, we almost give people too much information, right? There's, 20 harms, and it's like one is a little bit this way and one's a little bit that way. Like, how do you, weigh that against, 6 or 7 different benefits? And, some of them are permanent and some are temporary, and, all this other stuff. I think it actually makes it, it's, this principle of we want to have balanced reviews is really important. And, that's something that I've written about, and, our guidance for ARC and others has been based around that. But I think when you start thinking about kind of, what it all means, it becomes, you quickly start to see like how this is very challenging, and why people, readers, and even reviewers are kind of like, I can't deal with all this stuff. It's just too much to try to put together. And why, like in Riaz's example, the harms are summarized in a sentence, because there's, how do you like the paragraph Riaz had was beautiful, but it's like you can't put that in an abstract, right? Nobody there, that takes up like half of the abstract. And so how do you, what do you put as your main conclusion is I think often the issue here. So I didn't answer Peter's question, but just bringing up some of the I think challenges and how do you actually balance benefits and harms and actually come up with this final assessment. I think that's a big unknown.
Yeah, I think I'm gonna jump off that for another little point that doesn't really necessarily answer Peter's question, but it came to mind that difficulty in balancing it. Is it even sort of, where does the place lie for who decides that benefit or harm, right? I mean, sort of the balance is tricky because people weigh different harms differently, right? So for benefit things, it's for, that you pretty, core outcome sets for benefit outcomes are one way that you generally agree upon a set of things that people think of as important for showing progression or improvement in something. But for harms, everybody has different harms that they care about. Everybody has different things, will weigh even the same, any given set of harms differently for what their decision on whether they would take something. So it's sort of interesting, and maybe a challenge in sort of that weighing. Do we assess one thing or put weight on one thing, or do we give people everything to let them decide? That's sort of something I'm putting out.
Even in sort of the weighing, I agree, is hard, but I'm just wondering, are we ever going to get to more clarity on causality? Because, right, if the race is led by efficacy and everyone goes, okay, it's clear, the results are in, we see a difference and it was an RCT, it can't be explained any other way, we trust it, yet things take, months and months and years and debates and on, that seems like we're still in second-class citizen territory.
We looked at quetiapine and gabapentin, as you know, and there was a difference between those in that the quetiapine studies, which were done a little bit more recently, had a number of things like sexual side effects and weight gain that were assessed systematically. And it was clear that the regulator wanted to see data about those things. And that's because they had experience with lots of different antipsychotics, and they knew that they could anticipate those things and get good data that would allow you to compare one drug versus another potentially, and think about not only causality, but whether you get more of something on this drug versus other drugs in the same class. It was notable to me with the gabapentin ones that it's not the first drug in its class. There were lots of other antipsychotics before it. There were hundreds of preclinical studies looking at all sorts of different animals that would have picked up potential for, certain biologic effects, if not, things about the ways in which humans would respond to it. But, there were a lot of things that could have been assessed systematically in those trials, and nothing was assessed systematically. So I think I agree with you that if we continue to rely on non-systematic assessment, we are not going to get good data about causality unless there is a really strong signal and something just jumps off the page. The numbers aren't there in terms of event rates and patient populations in those early trials. And if we want information from trials that are done for regulatory purposes, I think that we probably want them to be assessed systematically.
Do you think that the question of it's really interesting that regulators had some concerns about potential adverse events that asked the manufacturer to specifically look into it with systematic data collection in the further studies? Is that something that systematic reviewers, do you think, can tap into, whether it's phase 1 trials, healthy volunteer trials, whether it's regulatory correspondence, whether it's looking at other drugs? How can systematic reviewers get a better sense of what AEs in particular should I have my eyes open to and be looking for and concerned about?
I'm happy to respond, but I think others probably have some suggestions too. The drug label is a good jumping off point if you're doing a review of a drug. You'll get a lot of information there because some of that is coming even from preclinical studies where there will be things that may be included, like quetiapine includes a warning about cataracts, which is referencing studies that were done in dogs. So there will be a mix of evidence that informs that, which might be a good pointer.
Yeah, I mean, so in we wrote some ARC guidance a couple of years ago about prioritizing harms, at least from the systematic reviewer standpoint, which is a little different from the regulator standpoint. But I think you can use a prioritization process, and there is this idea of talking to patients actually, and actually asking patients what they care about, which we all usually don't do. I think the problem is what patients care about is often not what clinicians think is important, or stakeholders. So like if you ask them about opioids, it's like, well, they care about constipation and nausea and sedation, but they think addiction is like nothing. It's like it's a low priority. Whereas and so you run into situations like that, where the way that stakeholders, in particular patients, value outcomes is very different, but we really don't account for that, I guess is all I'm saying, and maybe we should. I'm not sure how to do it in a way that kind of aligns with I guess the seriousness of adverse events, but it is striking sometimes how the things that reviewers and researchers think is important is actually not really what patients are most concerned with.
This is Mira. I wanted to use this opportunity to thank everybody. We're at the end of our 2-hour session, and I feel like there's probably another 20 hours of discussion left to go. I would encourage you to look at some of the discussion questions. There's a lot of rich information there as well, several good suggestions. I want to thank all of our panelists and our discussants. It's been a really valuable, rich discussion, and thank you, Jenjing, for putting this together. Right. Goodbye, all.
And don't forget, Cochrane have got in the handbook, there's a chapter on adverse events, I think. Okay.
Thank you, everyone.
Thank you all.
Thank you.